So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our Saturday ACTRAC Academic Program. Our today's speaker is Dr. Vipin Arora. Dr. Vipin is director and the head of the department in the GTB hospital, and he will be speaking on the topic types of parotidectomy and its various indications. With this, I welcome Dr. Vipin to go ahead with the lecture. Dr. Vipin, please go ahead with the lecture.
Very good morning, ma'am. I bring greetings from University College of Medical Sciences, Delhi University, and it is always a pleasure to talk to our residents who form core of the service. So I can start my presentation. Is it okay, ma'am?
Yes. Please go ahead.
Okay. So I'll share my screen. Do I need a permission from the administrator to share my screen?
I don't think so. You can just share the screen. You can use the passcode and the...
No, I'm logged in, but I'm unable to share this.
Rupal, can you please ask the IT people if something else has to be done? Hello?
Yes,
Rupal?
I need to be the host actually.
Yes, ma'am. 1 second, ma'am.
So this is not letting me share the screen.
Okay. Can you please make Dr. Vipin the co-host?
Yeah, I can.
Now we can see that.
Okay.
Yeah.
Okay.
Yeah.
So very good morning to all of you, and I have indexed my presentation. It's going to be a pretty long presentation, so please bear with me. I have divided into epidemiology and the surgical anatomy, which is a core of parotid surgery, then evaluation and decision making in parotid cancers, a treatment policy, and then we come to the classification and types of parotidectomy. Then I have a dissection video and which depicts the incisions which are used in parotidectomy, followed by some case discussions. And then we'll be discussing complication and the way to present those complications. So this is a plan for today, and I'll be discussing with you.
So Dr. Vipin, sorry for the interruption. Can you please put it on the slide share mode? I think it's not on that mode.
You're not able to see the first slide? You're not able to see this?
Yeah, we can see the index. I think it is on the slide share mode. Not sure about it. We can see other, like the site, all the other
windows also.
Yes, not the other windows means I think slide share where we can see only one this one slide.
I'll do it again. I have to stop sharing first, then again I'll share it. So now can you see it, ma'am?
Okay, please go ahead, Dr. Thank you.
Okay. So this is a plan for today, and I'll be going through the first slide. So this is from the SEER database. This is the incidence of all cancers in the whole human body. The incidence and the mortality. This SEER database is one of the most reliable databases available for United States. And if you see, the incidence of cancer is gradually decreasing. So this may partly be attributed to the decrease in the tobacco consumption, or maybe better awareness or better healthcare facilities. We do not know, but it is decreasing, and the mortality trend is also is decreasing. So this mortality is decreasing over the period of time, which is good. But when we look at the data for the salivary gland tumors, this has been pretty flat. So the incidence is also not on the rise. It is almost flattened, and mortality is also flattened. So there has not been much change over a period of time. This data pertains for almost for the last 40 years or so, and this has been, and the incidence and the mortality has been pretty the same. But there has been some changes in the distribution of cancers. The salivary gland cancers, which form around 1 to 5% of all head and neck cancers, there has been increase in the incidence of uh, mucoepidermoid cancers, N plus, M plus, and there has been decrease in the incidence of adenoid cystic carcinomas and the carcinoma X pleomorphic adenoma, which arises over a period of time from the pleomorphic adenoma.
Sorry for interruption, sir. Sir, the slides are not moving.
Now it has moved to the next one. Can you see a graph?
No. It
pink
is
line?
index slide only, Dr. Vipin.
It is index only. It's not
Yeah,
moving.
yeah. No. We can't see the next slide here.
But I'm sharing it. I don't know. Okay. I'll do it again, ma'am. I'm sorry. Sorry for that.
No problem. Please do. Slide share, you can, yeah. Yes, now it is moving. Yeah.
Now it is moving, ma'am? Okay.
Yeah, it is moving.
Okay. So sorry for that interruption. And I was talking about so this is the for all the cancers, and this is salivary gland has been pretty flat over a period of time. Now it's moving, ma'am. It's moving, ma'am. The slides are moving.
Sir, we can see the sheer database. You have like all cancer sites combined, sir. That slide we can see right.
I don't know why. What's the reason? But I have moved another two slides.
Sir, before sharing your window, sir, you have to put the PowerPoint on slideshow mode, and then you share your screen, so it will work.
I'll do it again. I'm sorry for that. So
Yeah, we can see the slide. Can we put it on slide share? Is it possible? Or it is not coming here?
it's already.
On
Can you see
slide,
salivary gland, the SEER incidence?
Yeah, we can see. Yeah.
Okay. And did it move to the next one, the anatomy?
Yeah, as you wish. Yes, we can go to the next slide. If there is any problem, I will let you. Please go ahead. Yeah.
Can you see the anatomy, the human anatomy part of parotid region? Is it visible now?
The next slide? No,
Yes.
it is not next slide. No. I can see the salivary gland share incidence from 2017 to 2020.
I'll do it again. I'm sorry. I don't know what's the reason. Can IT person can you help me somehow? What's the reason? What's the problem?
Dr. Vipin, I think some student has written you can click on each slide every time. So we can go to each slide every time and we can click that. Even I am not very good in this. So.
Okay. I think COVID is over. I think we have all
so we can go to each slide every time and we can click it. That also we can do. That they are suggesting.
So is the anatomy visible now?
I think the screen share has has been lost. So we can see the anatomy slide. I think we can go every slide we can click again and again. Like every slide we can click. Yeah.
Okay. So this is the anatomy of the left parotid region, and we can see pretty much the facial nerve is the center of all parotid surgery. The index operation is a total parotidectomy, and the facial nerve traverses right through the substance of the parotid gland, and then it emerges out and supplies to the muscles of facial expression. So the center stage is occupied by the facial nerve. So this is a dissection of the left parotid region. This is the pinna, and this is the mentum, and you can see the trunk of the facial nerve emerging from. Ma'am, is it visible? Because I don't know. I'm talking to. Ma'am, is it the anatomy?
Visible. Yes, sir. It is visible. The face with the photograph, right, sir? It is visible. Sir.
Okay, that's good.
Yeah.
Okay. So this is this is the pinna of the patient, and this is the mentum side, and you can see a picture over there. The facial nerve emerges from the stylomastid foramen, and this main trunk you can see over here. It emerges from the stylomastid foramen and then divides into upper trunk and the lower trunk, the temporozygomatic and the cervicofacial. This is a digastric muscle, the anterior belly of the digastric muscle of the posterior belly. This is a retromandibular vein, and this is a tragal pointer. So this is a anatomy of the main trunk of the facial nerve as it enters into the substance of the parotid gland. So this is another view in which the facial trunk can be seen, and then the upper and the lower divisions can be seen, which divides further into buccal, marginal mandibular, and cervical branches. This is the posterior belly of the digastric muscle, and the facial nerve will lie in the level of the posterior belly of the digastric muscle. And this is a tragal pointer, and this nerve is emerging from the stylomastid foramen. This is a styloid process which is in the deeper relation to the parotid gland, and the deep lobe of the parotid gland is in relationship to the pre-styloid compartment of the parapharyngeal space. So this is the basic anatomy, and again the zoomed up view of the same side, and with all the branches of the facial nerve. So lower part of the parotid gland is in relationship with the retromandibular vein, and the last two branches, the marginal mandibular and the cervical, crosses over the facial, this retromandibular vein, and can thus be identified with the relationship to the retromandibular vein. So before we actually move to the current and the future, so we must know the history, how we reached over here. And this is a brief history of salivary gland surgery. So way back in early 19th century, it was American scientist McLean who first performed a total parotidectomy for parotid cancer in the United States after ligating the external carotid artery. And obviously, this involved the sacrifice of the facial nerve, where there was no consideration given to the facial nerve.
I'm
Yes,
really sorry. Really sorry. Slides are not moving again. We are on the same slide that facial nerves we are.
ma'am.
Yeah, we can see now. Yeah, brief history of saliva.
A brief history of saliva.
Yeah,
Okay, so I think I can move one slide at a time, I think.
exactly. You can click
Without
on
moving.
each slide every time. Yes.
Now are they moving, ma'am?
Yeah, now they are. Correct.
Okay, so that is without slide mode. Okay.
Yeah, this is better. Yeah.
So the Ferdinand was is a German scientist in mid of the 19th century, and he first devised a concept that facial nerve can actually be preserved during the salivary gland surgery and parotidectomy. So this was a novel idea of the time, and then subsequently, Codrenu was the first to perform total parotidectomy with preservation of the facial nerve. So the current or the modern parotid surgery.
So please go ahead. I think we can see that slide, brief history of salivary gland surgery.
But mine is not moving now. Okay, let me try some other one. So the modern history of salivary gland surgery. We all are familiar with the name of the Blair. There is an incision, Blair incision, and modified Blair incision after his name. He's the one uh, who brought in the concept of localizing antegrade localization of the facial nerve before removing the parotid tumors. And that too, the facial nerve was located at the digastric muscle. So the anterior of the medial border of the posterior belly of the sternocleidomastoid was a landmark by which the facial nerve was identified, and then it was the tumor was removed only after the identification. Then the Bailey is the one who modified the Blair incision and who popularized the concept of facial nerve identification. And subsequently, the Hayes Martin was the one who popularized this procedure in the United States. And the current surgeries that we perform by antegrade identification of the facial nerve was popularized by Dr. Hayes Martin. And on the right side, you can see the picture. This is from the original article of Hayes Martin, and you can see the current concept of the facial nerve preservation and dissection. This is what was described by the Hayes Martin. You can see a surgeon's view where the surgeon can very well see the facial nerve and can move and dissect the branch of the facial nerve before actually removing the tumor. So when we come to the distribution of tumors, so parotid is by far the most common site of salivary gland neoplasms, followed by minor and submandibular gland neoplasms. But most of the neoplasms in the parotid gland, they are benign in nature, and most of the neoplasms in the minor salivary gland, they are malignant. So this is a ratio in which these neoplasms are found. And if you look at the proportion of cancer in these neoplasms, the parotid has a least incidence of cancers in these neoplasms. But by far, by the sheer number of parotid neoplasms, the parotid malignancy is the most common tumor of in the salivary gland tumor. It's the most common site. The histological distribution is most common is the mucoepidermoid carcinoma, followed by adenoid cystic adenocarcinoma, the mixed tumors, and this is a distribution for salivary gland tumors. If you look at the NCCN guidelines, NCCN recommends fine needle aspiration cytology as an initial investigation. So all the FNACs in salivary gland should be categorized by the Milan system of reporting salivary gland cytology, and with the risk of malignancy in each specimen should be defined. And an FNA examination should be able to tell you if it is indeed a salivary tumor and if it is not a non-salivary tumor like a lymphoma. And it should also be able to categorize a tumor into benign and malignant. And so subsequently, they could be dealt accordingly. But there is such a large number of diverse histopathology in salivary gland tumors that it is virtually not possible for the cytopathologists to identify each category of these tumors. There are more than 20 categories of cancers which are defined by the WHO classification. So it is a very diverse group of tumors, but cytopathologists will be able to tell you if it is a benign or a malignant tumor, and that is the most important concept in salivary gland cancers. After a local examination and by FNAC and subsequently by CT scan or MRI images, the surgeon should be able to have a reasonable confidence in identifying a benign and a malignant tumors and should be and deciding a plan accordingly. Know your tumor and your patient very well before you actually embark onto the surgery. Some of the tumors are notorious for distal metastasis, like the adenoid cystic carcinoma. So, chest CT scan for evaluation of distal metastasis should also be done, besides other general workup for head and neck cancer patients. For early stage and early grade tumors, that is T1, T2, T1, T2 tumors which are low grade tumors, a surgery less than a total parotidectomy is sufficient. A superficial parotidectomy in a tumor which is located in the superficial lobe may be sufficient if there are no adverse risk factors present, and if there is no adverse feature is present during the surgery or in the follow-up histopathology report, so that should be sufficient. Except for the adenoid cystic carcinoma, in which the adjuvant radiation is almost always indicated. For advanced cancers, surgery is a cornerstone, and total parotidectomy with or without preservation of the facial nerve, depending on the status of the facial nerve, is a treatment of choice. So, in all the cases where the patient has walked in with an intact facial nerve, all attempts should be made to preserve the facial nerve function in those patients, even if it involves leaving behind some microscopic tumor residues. So you do whatever, and try to create a plane between the tumor and the facial nerve, and try to dissect off the tumor from the facial nerve and preserve the function. In other unfortunate cases, when the facial nerve is being completely encased by the tumor, so those are the cases in which the nerve need to be sacrificed, and immediate reconstruction should be attempted in those cases. Then there's a category of cases in which there's no resection possible, and they will go for a definitive chemoradiation. As far as the neck is concerned, all clinically positive necks, just like for all other head and neck cancers, they will go for neck dissection. Level 2 to 2, 3, 4 is sufficient for therapeutic dissection for clearance of all the draining lymph nodes. And if the tumor is extending anteriorly and is placed anteriorly, then you need to address level 1 lymph nodes, and if it is located posteriorly, then level 5 lymph nodes should also be considered for inclusion in the neck dissection specimen. And for N0 neck, when there is no clinically apparent metastasis, so high grade and high stage tumors obviously will have to undergo a neck dissection, which is an elective neck dissection. So level 2 and level 3, they are sufficient levels to be dissected. And in case there is any adverse histological feature in the histopathology report, so these patients, they will require adjuvant treatment in the form of radiation. Then I'll come to the types of parotidectomy. Bailey has defined depending on the preservation or excision of the facial nerve. So it can be conservative parotidectomy if the branches of facial nerve are preserved and spared, and in the radical, when the facial nerve is excised. And all these terms they are self-explanatory. Superficial parotidectomy, obviously, and deep is self-explanatory. Total parotidectomy, when both the lobes are included in the resection. Then partial superficial parotidectomy, when you do not formally dissect the facial nerve, but only the branches which are relevant to the tumor. Then there's a concept of extracapsular dissection, in which it is basically for small superficial tumors located and which are movable on inspection. And no facial nerve dissection is done in these cases, and there is no cuff of tissue which is preserved around the tumor. And the radical parotidectomy, we all know the facial nerve, and along with other structures like masseter muscle, mandible, or lateral temporal bone resection, that they are included in the category of radical parotidectomy. Then there are other classifications given by other authors, but they are more confusing. So this classification given by European salivary gland surgery group is the one which is interesting. So it has divided parotid gland into 5 levels. So, and the lateral part is the superficial lobe is the upper part of the superficial lobe is level 1, lower is level 2. The lower part of the deep lobe is level 3, and the upper part of the deep lobe is level 4, and the accessory parotid is categorized as level 5. So you basically to name or to classify a parotidectomy, you just use a Roman numeral as to which level has been excised, and along with the other structure which has been excised besides the salivary structure. Like for say in this, it is parotidectomy 1 to 4, along with sacrifice of the seventh cranial nerve. Facial nerve has been sacrificed, and the skin has also been removed with, and the masseter muscle has also been resected. So that makes the classification pretty straightforward and easy to reproduce and communicate. So this is a European salivary gland consensus group classification. Then I come to the parotid incisions, because it is right in the middle of the face, so nobody wants a scar which is readily apparent or which is ugly. So these are the various incisions which have been defined. The most commonly used incision is a modified Blair incision. I'll come to this a little later. The other incisions which are used is a facelift incision, in which there is a preauricular extension, and then it goes around the lobule into the post-auricular area, and then it merges into the hairline. Similarly, the retroauricular incision, it doesn't have any anterior limb, and it starts near the lobule into the retroauricular area, and then goes into the hairline. So advantages of these incisions is basically that is a cosmesis, but they are otherwise difficult to manage, and the surgical difficulties there, and they cannot be extended into the neck when you are planning the neck dissection for these patients. Then is a U-shaped incision, in which there is a pre-auricular extension and around the lobule, and then to the post-auricular area. Then I come to the modified Blair incision, which is the most commonly used incision, and this is an incision, and this is an incision. It starts in front of the tragus, and then it curves around the lobule and goes to the tip of the mastoid, and then it curves into the upper skin crease towards the hyoid. So this is a classical modified Blair incision. The Blair incision, the original Blair incision was it had a preauricular extension and an acute L. That is it is an inverted L-shaped incision. So this was the original Blair incision, and this was subsequently modified into a modified Blair incision like this. And if you see in this picture, there is another incision which is an lazy S incision. The preauricular limb is the same, but rather than going all the way to the mastoid, it curves obtusely and then continues into the then continues along the anterior border of the sternocleidomastoid into the upper skin crease. So the advantage of the lazy S incision is that it prevents a necrosis of this limb or this tongue of the modified Blair incision, which has got a precarious blood supply. So lazy S incision is also a substitute to the modified Blair incision. The advantage of modified Blair incision is it gives excellent visualization of the entire parotid parenchyma, excellent view of the tumor, of the facial nerve, and it is a very robust flap. The lower part of the flap is raised along with the platysma muscle, and it has got a very good blood supply. And then extension can also be made into the neck if you are contemplating to do a neck dissection. And this is cosmetically quite acceptable. And after a few years of the surgery, it is barely noticeable. So these are the advantages of modified Blair and the other available incisions for conducting parotidectomy. Then another important concept to understand is a SMAS. So the upper part of the modified Blair incision is raised in a plane which is subdermal. So subdermal plane is actually just below the dermal fat. This is dermal fat, and it is above the SMAS plane. And this is a avascular plane between the skin and the and the SMAS, and it is raised in this, and then it has got a very good cosmesis, and an excellent exposure can be maintained. This flap is also robust because it is supplied by these subdermal vessels. And in the neck, it is raised below the platysma, though it can also be raised above the platysma also. Then I have this short video of can you see the video, ma'am? Is it visible?
Yes, sir, I can see. Yes.
So this is a modified Blair incision, which is being marked. This is a left parotid region, and the incision is extended into the post-oral around the lobule towards the tip of the mastoid, and then it curves gently into the upper skin crease towards the hyoid. So this is a modified Blair incision which has been marked. And then a scalpel is used to deepen this incision. This is actually the Blair incision, which I was talking earlier. It has got only two limbs, the anterior and the posterior one. And then a suture is passed through the lobule. It aids in retraction of the lobule, and you can manipulate this part is difficult to make incision, so you can retract it with the suture, and then place incision in the preauricular area, and then you can manipulate the lobule, and then you can extend this incision into the around the lobule and the tip of the mastoid into the neck. This can further be extended into the neck if you're planning to do a neck dissection in such a case. Then preauricular incision is extended, it is deepened. So in live patient, this step is done with a cautery because there's so many vessels over there. And this is a cartilaginous external auditory canal which is being defined. So if you go in a plane which is along the cartilaginous external auditory canal, so that is quite helpful. And you can this is a sternocleidomastoid muscle, and we're going to define the anterior border of the sternocleidomastoid. This is the anterior sternocleidomastoid muscle, which is being defined. So you define the anterior border, and then raise this flap anteriorly over the parotid fascia, and below the subdermal this fat, and there's a fat above and there's a fat below, and this is a parotid tissue which is being separated from the anterior border of the sternocleidomastoid. In the depth, the posterior belly of the digastric. So this idea of depth of the facial nerve, at which depth you should be able to locate the facial nerve. And then you retract the lobule in a posterior and superior direction, and then try to locate a facial nerve as it emerges from the stylomastoid foramen. So, the trail pointer is the most common landmark for this, though it is the most inconsistent because it is a mobile marker. So once you identify the facial nerve trunk, then you go along the branches of the facial nerve, the upper division and the lower division, and also see the relationship of the main trunk with the posterior belly of the digastric muscle, the anterior border or the medial border of the posterior belly of the digastric muscle. And this is the depth at which the facial nerve will be seen. Then the tympanomastoid suture line is another landmark, and the facial nerve will be 1 to 2 millimeters deep to the tympanomastoid suture line. And you continue the dissection along the branches of the facial nerve, insert and along the branch, and lift it and thread and cut it. So this is how it goes, and you will be able to safely conduct the neck dissection. And the parotid tissue should only be removed once you have identified all the branches of the facial nerve. So move to the next slide. So no discussion of parotid surgery is complete if we don't discuss the pleomorphic adenoma. So this is a usual situation in which the patient has a painless lump in the just below the lobule of the ear, and it is painless. A young patient who has come to you, and this is on CT scan. This is a tumor which is a pretty defined tumor in the superficial lobe of the parotid gland, and rest of the parotid gland is free. And these are the patients who will be evaluated by FNAC, and there will be report of pleomorphic adenoma, and these patients can safely be managed by superficial parotidectomy. Then if you have a case like this in which you are unable to insinuate your finger between the ascending ramus of the mandible, the posterior border of the ascending ramus of the mandible, and the mastoid, so you must expect a deep lobe involvement in such cases. So imaging is advised in these cases where you can actually assess the extent of deep lobe invasion. So this is a CT scan of the same patient in which there is involvement of the deep lobe also. So this patient can be managed by total conservative parotidectomy with preservation of all branches of facial nerve. Then this is a treatment policy for pleomorphic adenoma. I have discussed superficial parotidectomy and total conservative parotidectomy in these two cases. And then there is a concept of extracapsular dissection in which the small localized tumor in the superficial lobe of the parotid, they are addressed by taking out the tumor without any cuff of normal tissue, and the results have been found to be pretty good. There's no formal dissection of the facial nerve done in these cases, so there are less chances of injury. And in case of there's a histopathology is suggestive of some malignancy, then these patients can still be treated by a formal parotidectomy, because the facial nerve field is still virgin in these cases and can then be accessed, and then the facial nerve can be dissected and preserved in these cases. Partial superficial parotidectomy, again for small tumors, it can be done, and there's a cuff of normal tissue of around 1 centimeter, which is taken all around the tumor, and only the branches of facial nerve which are in that area of the tumor and in that normal cuff of tissue, they are only dissected, preserving the other branches. So there are lesser chances of Frail syndrome in these cases. The lesser scarring is there, and the post-operatively it is cosmetically better. But how oncologically safe it is, the time will tell us. Then what to do in cases of deep lobe tumors? Deep lobe tumors per se are quite rare, but most of them, fortunately, are benign tumors. They are pleomorphic adenomas arising from the deep lobes, and total conservative parotidectomy is required in these cases after dissecting out the branch of the facial nerve. And one of the peculiar problem that we have with the pleomorphic adenoma is the spillage of the tumor. That because of the improper handling, these tumors can burst and can release their contents and the tumor substance into the surgical field, and thus increasing the chances of recurrence, which are pretty bad in cases of pleomorphic adenomas. And if there is a spillage during the surgery, or if there's a rupture of capsule, try to remove as much of parotid tissue as possible, irrigate the tumor properly, and try to remove whatever spillage has happened, and hope for the best. This is one of our patients who underwent a parotidectomy elsewhere. This is a parotidectomy scar which can be seen, and this patient developed recurrence. Recurrences in pleomorphic adenomas are multifocal, and they are adherent to the skin and the previous scar. So these cases, they are quite challenging to manage when the facial nerve has already been dissected out. So the risk of facial nerve paralysis in future surgeries is very high, and since they are fixed to the skin, so skin also need to be excised in these cases. So these are quite challenging. This is also another case in which the pleomorphic adenoma, the recurrence is over there, and it is multifocal and involving the previous scar. And this is also a recurrence of pleomorphic adenoma, but fortunately, this is the only scar anteriorly. So I believe that formal facial nerve dissection has not been done in these cases. So these cases are relatively easier to manage because the facial nerve has not been dissected in the index surgery. So you can dissect it and then remove the tumor. Then I'll come to the few cases of malignant tumors. So this is a common presentation when the patient has a parotid swelling and ipsilateral facial nerve paralysis. So these are the advanced cancers, and these are the advanced parotid cancers, and the surgery is a primary modality if they are resectable without leaving any significant tissue behind. And total radical parotidectomy with the neck dissection would be a procedure of choice in these cases. And these patients, older patients, they are difficult to rehabilitate, but attempt should be made to bridge the gap for the facial nerve, and the post-operative radiotherapy is a routine depending on all the histopathological features. Then another patient with parotid cancer and facial palsy. So this is a patient having tumor in both the superficial as well as the deep lobe, and it is very difficult for a person to resect these tumor in totality. And but still, once the facial nerve paralysis is already there, that makes the thing relatively easier. So you can do an en bloc resection and then decide on the adjuvant treatment depending on the histopathology in these cases. But they will all require radiation in the post-operative period and surveillance. But the more challenging are these sort of cases when the tumor is pretty advanced. This is an old patient with intact facial nerve. These are the really challenging cases in which all attempt to preserve the facial nerve should be done. Facial nerve need to be preserved in these cases, and in case it is found to be fully encased during the surgery, and the tumor cannot be removed without sacrifice the facial nerve, then if there is any doubt, then the frozen section can be done during the surgery for the margins, and also to determine the histopathology of the tumor, and to confirm the diagnosis of malignancy in these cases. Frozen section can also be done during the surgery before resecting onto the facial nerve. So as I was discussing earlier, it is very important to discuss the facial nerve prognosis in these patients. Patients who have intact facial nerve, they are the one who makes most of the fuss if there is inadvertent injury or there is sacrifice of the facial nerve. So always discuss with your patients in detail and always explain them that there is a real risk of having a facial paralysis in this patient, and there will be problem of the facial paralysis. Then these are also advanced cases which require a resection with the neck dissection and subsequent adjuvant treatment. Then this is one of our patient who presented with ductal cell carcinoma along with the metastasis in the neck node was clinically palpable. So neck dissection, as per as NCCN guidelines for a positive neck, all the necks need to undergo a therapeutic neck dissection, and for parotid, the therapeutic levels are level 2, 3, and 4 at least. And this tumor is extending anteriorly, it is localized anteriorly. So I would like to address level 1 in this case also. I would not leave a level 1. And if the tumor are located posteriorly, if the main bulk of the tumor is lying posteriorly, then a level 5 also need to be included in these cases. And a comprehensive level 1 to 5 dissection need to be carried out in these cases. Then this is a patient of an isolated deep lobe tumor which presented as a pharyngeal mass or as a bulge in the lateral wall of the pharynx. This is a deep lobe tumor. This is a CT scan. I'm sorry for the quality of the CT scan, but this is how the pharynx is compressed and the tonsil is pushed medially. So these deep lobe tumors, they need to be tackled by a transparotid and a transcervical approach, in which the transparotid approach is used to delineate the facial nerve, and the transcervical approach can be used to remove the deep part of the deep lobe tumor. And this should be distinguished between the primary tumor of the parapharyngeal space. This is another patient with a primary tumor of the parapharyngeal space. Same presentation, same bulge in the tonsil and the soft palate. But you can differentiate them on the basis of imaging. So if you pay attention, then there is a plane between the tumor mass and the deep lobe of the tumor. So this is a fat plane which is preserved in cases of primary tumors of the parapharyngeal space. Primary tumors of the parapharyngeal space are also mostly pleomorphic adenomas. So once you see this plane, it is preserved. So this is a primary tumor of the parapharyngeal space. And if this plane between the deep lobe and the tumor is obliterated, then it is obviously a tumor which is arising from the deep lobe of the parotid glands and need to be tackled accordingly. And once the tumor goes into the ear canal, or then they all need to be tackled by a lateral temporal bone dissection at least. Sleeve resection is not the procedure of the choice, and along with the parotidectomy, one need to do a lateral temporal bone dissection in these cases. And if the tumor is extensive involving the pinna and the surrounding skin, then it is not always possible to close these tumors primarily, and you need a flap for reconstruction. Like in this case, this was a revision adenoid cystic carcinoma, in which the pinna was involved and then the surrounding skin was also involved. So we did a radical resection, lateral temporal bone resection with a neck dissection and a radial free forearm flap for reconstruction of this defect. But this patient failed distally, as usually is the case with all adenoid cystic carcinomas. When she presented, she had distal metastasis, but they were asymptomatic. So you can consider doing a palliative surgery in adenoid cystic carcinoma with distal metastasis which are asymptomatic and stable. This is one of our patient who had a very advanced parotid cancer, and this is axial CT scan of this patient. And the tumor is everywhere, involving the masticator space, involving the great vessels, and also the muscles of the paraspinal muscles also. So this clearly is not a case for any resection, and this is a a candidate for definitive chemo radiation. So this is a PET scan of the same patient. The PET scan for salivary gland cancer is mainly indicated for surveillance, and because the FDG avidity of salivary cancers is not very predictable, and adenoid cystic carcinoma can have very low avidity for FDG as compared to the Warden's tumor, which is a benign tumor, and it lights up with FDG. So it is not very reliable. But for advanced cases in which you are contemplating to delineate the distal metastasis, FDG PET can be done. Then obviously the facial nerve, which is a center stage of parotid surgery. So there are many scenarios in which the facial nerve can be injured, like with the cautery or with the stretch, and or it can be sacrificed due to the tumor factors. All attempts should be made to reconstruct the facial nerve, and the most commonly used graft is a auriculotemporal nerve, is a greater auricular nerve, which is readily accessible from the operative field only, and can be used for reconstruction. Then finally, I'll come to the complications of parotid surgery. Obviously, it can be hematoma, or there could be accumulation of saliva in the wound, and that saliva could release and forming a salivary fistula. So keep a drain for a couple of days till the drain amount decreases significantly, and then you remove it. And if even after that, if the seroma forms, just take a white bore needle and suck out the serous fluid and give a pressure dressing. Another common problem, particularly in females, is a numbness of the lobule. Numbness of the lobule is usually not appreciated by male patients because they do not wear any ornaments in the ear, but they are readily noticed by the ladies. So it can be prevented by preserving the posterior branch of the greater auricular nerve. So if you preserve this branch, and this is sensory supply to the lobule. So if you preserve this, you can prevent the complication of numbness. This is a very common scenario after the parotid surgery, where the marginal mandibular branch is the only one which has been affected, and patient is cosmetically concerned about this facial disfigurement, and most of it is because of the stretch, because the marginal mandibular is a very delicate nerve, and while dissecting and while performing the dissection, they get stretched and leading to this temporary paralysis. But no treatment is required for these cases, and it will resolve over a period of time from 5 to 6 weeks, and the patient will be all right. All they require is an assurance. Other common problem that we see is a phrase nerve. This is because of the aberrant innervation of scletomotor postganglionic scletomotor fibers, which were earlier supplying the parotid gland, but after the surgery, they are aberrant supplies to the sweat glands. So every time the patient eats something, there is hyperhidrosis in this part, and then there is redness in this part. So this is troublesome. So Miner's scratch iodine test is a one in which the iodine is first painted, and then the starch powder is then sprayed over it, and then the patient is given some lemony candy or something to eat, and then you can see the starch and the iodine reaction leading to a uh, blue formation because of the sweat of these patients. So this can also be prevented by rotating a sternocleidomastoid muscle. A superiorly or inferiorly based sternocleidomastoid flap can be used to reconstruct it and to provide a barrier between the skin and the underlying tumor bed. Also, the temporoparietal fascia and temporoparietal muscle can also be rotated into the area, and then this problem can be prevented. This and botulinum toxin can also be injected into these site but the effect is temporary and it needs to be repeated after some time. So this was all about my presentation. So I have reached at the end of my presentation. So Dr. Gauri, Dr. Poonam.
Dr. Poonam here. Hi.
Sorry.
No problem. So I think there are, thank you, Dr. Vipin, great lecture. I think there are a few questions if you would like to take them.
Sure.
Or shall I read it to you?
That is why I skipped the follow-up part so that we can have a few questions.
Yeah, sure. So I think so this is what is valley of nerve, they have asked. I think that internet question it is. So so I think that hello. Yes, Dr. Vipin. So I think there is one question, deep lobe, high grade mucoepidermoid carcinoma abutting the ramus of mandible. Do you need to do posterior segmental mandibulectomy for margins or excess? What reconstruction would you advise?
Advanced cases of salivary gland cancer, if there is significant erosion of the mandible, they do require segmental mandibulectomy. And most of these cases, they do not require any reconstruction because they are quite posterior, and soft tissue reconstruction is usually adequate for these patients.
So what is your experience on primary cable nerve grafting of lost segment of facial nerve during surgery for malignancy?
So as a policy, we do reconstruction for all the patients who are younger than 60 years of age because it is easy for them to undergo rehabilitation. Older patients, they find it very difficult to rehabilitate. So in those cases, what we do is we provide them with a gold eyelid implant, and that's it, and give them facial exercises and all. And we do not want to complicate any matter in these cases, and we want them to undergo radiation as early as possible. And but for younger patients, we do reconstruction by cable graft in all the cases.
So what is the role of facial nerve monitoring? How much is its efficacy? I think intraoperative nerve monitoring they are talking about.
Intraoperative nerve monitoring is an excellent tool if you have it, and particularly in cases of revision surgeries and recurrent tumors where there's so much of scar tissue and the facial nerve has already been dissected. So it is an excellent tool if you have the facilities, so use it and try using them in normal cases. In normal cases, like the cases which has not been operated, get used to the system, and only then use them in difficult cases.
Yeah, it is quite useful in recurrent cases. Yeah, like but you rightly said, you have to reach till the nerve actually, because if there is a lot of fascia or tissue or blood over it, you will not be able to use it effectively. So even to use the IVNM, you have to know that. How to prevent a silocele?
Silocele, basically you can in cases silocele is actually produced from whatever is left behind after the parotidectomy. So this is still the tissue which is producing the saliva. So you can delay the removal of drain for a few days if the saliva is coming into the drain. So you can delay the removal of the drain for another couple of days, and then maybe give a pressure dressing in these cases, and most of these cases will resolve on its own. So you might have to do maybe aspiration a couple of times and give a pressure dressing, so they would resolve automatically.
And I think, Dr. Vipin, it is not very common also. Even after superficial parotidectomies, we don't see it very often. So what is your experience?
Rarely it happens, ma'am. Rarely it happens. And usually
Really?
patient comes to us after a week of discharge. When they have been discharged, and then they'll come that there is some boggy swelling, particularly it is hanging down. Because of the gravity, that fluid and that part is hanging down. And it happens mostly in the older patient where the skin is not very tight. Skin is loose, and then this is my experience that it happens usually in the older patients.
Yeah, I think it has to do with the, like you rightly said, the post-operative drainage. So if it is, you have put a drain, it has drained well, and the flap has stuck to the parotid tissue under then there are less chances of a silocele, because we don't see that very often. So how to reconstruct the facial deformity post-parotidectomy?
Facial, could you please say that again?
Deformity, I think facial deformity parotidectomy.
So facial deformity means facial paralysis, or?
No, I think they mean to say that defect, because if you have done a total parotidectomy, there will be some depression, I believe. That is the question.
Okay.
Yeah.
So whether to, I think they're talking about the depression that is caused after the parotidectomy. So which is disfiguring. Earlier the patient had an elevation, and after the surgery there is a depression. So one can use a superiorly based sternocleidomastoid. The upper third of the sternocleidomastoid muscle can be used and rotated into the surgical bed, and can be sutured over there. But there are issues with that. Basically, is that it can actually mask the recurrence of a malignancy. So, in cases of malignancy, I would not like to use a sternocleidomastoid flap to reconstruct or to obliterate that depression. The second option is a temporoparietal fascia, and with the muscle can be used. It can be rotated inferiorly, and then can be used to fill that defect. So that can also be used, but I would not recommend them in cases of malignancy.
Correct. So management of low-grade mucoepidermoid carcinoma with distorted planes with condyle and intact facial nerve.
So that is a very challenging case. So in case it's a revision surgery, these are the cases in which you should be using the facial nerve monitor, and surgery is a primary modality of treatment, and try to take off whatever is left behind. Many times it is not possible to know which tissue actually it is. It is a scar tissue, if it is a residual tumor, or it is a residual normal parotid tissue. So it is very difficult to make out, and particularly when the previous surgical notes are not available. So we get lot of patients who do not have any previous surgical notes, no previous histopathology. It's just a scar, and then they come for resurgery. So it is very difficult for a surgeon to decipher which sort of pathology they're dealing with. And it starts like as a fresh case. You get a repeat FNAC done, and it starts from there, and we work them as a normal per primum cases. So, but the surgery is very difficult in these part, particularly if you are considering preservation of the facial nerve in these cases.
Yes, I completely agree. Is salivoma and seroma same in the parotid surgery? Hello. Hello, Dr. Vipin, can you hear me? Hello. Hello. Hello.
Yes, ma'am.
Dr. Vipin, is salivoma and the seroma are the same in parotid surgery? This is one of the questions.
I think they're the same.
Right. I think there are lot of questions for you. I thank you for your patience. I think many questions. I think, what is the dosage of Botox given for Frey syndrome? Many questions.
See, Botox is available in our hospital with the plastic surgery department. They are the one who use it for the crow feet and for bro lifts and all these things. So they are the one who use it, and it is quite an expensive medication. So I don't know the dose actually.
Even I don't know. So what the deep lobe high grade mucoepidermoid carcinoma? So we already I think
Yes.
that then parotid tumor involving the superficial and deep lobes and facial nerve and also part of inferior bony external auditory canal, pinna and cartilaginous EAC is not involved. What is the adequate management of involvement of bony EAC?
See, the minimum surgery that you can do for involvement of the external auditory canal is lateral temporal bone resection. Anything less than the lateral temporal bone resection, and also you need to remove the entire skin of the external auditory canal. That is not serving the oncological purpose, but it is definitely for reconstructive purposes. You want to do a blind sac closure in these cases. So you want to remove the entire skin from the external auditory canal and then do a blind sac closure after doing a lateral temporal bone resection. And send these patients for radiation as early as possible, as quickly as possible.
Correct. So what is your experience on primary? I think we already discussed this thing. Primary cable nerve grafting of lost segment of facial nerve during surgery for malignancy, soft tissue like sternomastoid flap. These are two different questions, I think. When to suspect distant mets and do PET-CT?
See, if you look at the NCCN guidelines, NCCN doesn't recommend PET-CT scan for salivary gland tumors because of the very unpredictable FDG uptake in salivary gland tumors. But if you are suspecting distal metastasis, particularly in a cases like adenoid cystic carcinoma, where we usually see which have got a high propensity for distal metastasis, so CT chest without contrast is a good investigation, and it can be followed up with the FDG PET also, but they're relatively unpredictable. They're not very good investigation. And if you find mets in those cases, if they're asymptomatic, so better leave them alone and follow up these cases, because the morbidity in these cases is basically because of the loco-regional disease, and the mortality is because of the distal metastasis. So do not give any treatment, because the treatment toxicity that overweighs the any benefit which we get for treatment from these patients.
So one last question, Dr. Vipin. This is any role of elective neck dissection, and what levels to be addressed if we have to do elective neck dissection?
See, in an N0 setting where the tumor is a high grade or high stage tumor, there is no evidence of regional metastasis. So elective neck dissection should be done in these cases, and the specimen should be sent for examination. The second option is that you dissect only level 2. You dissect only. Am I audible, ma'am?
Yes, sir, you are audible.
You dissect only level 2 lymph nodes, send it for frozen section, and if they are positive, then you can go ahead and do a formal neck dissection comprising level 2, 3, and 4. But otherwise, level 2 and 3 are good enough for an N0 neck.
Yes, sir. I think, thank you so much, Dr. Vipin. This was such an... And there were a lot of questions, and you patiently answered each and every one. And with this, I really thank you. Great lecture. Thank you once again.
Thank you, ma'am.